Okay, so our next section today is entitled the Macrilen Stimulation Test for Growth Hormone Deficiency. Because MAGIC has sort of specialized in growth hormone, I thought this was important. This is a pretty new test that many people may not know about it, so hopefully you'll find this interesting. As we went before, there's different hormonal axes from the least likely to be affected, the most preserved down. You have the corticotrope axis, CRH, ACTH, cortisol. You have the thyroid axis, TRH, TSH, T4, T3. You have the gonadal axis, GnRH, LH, FSH, testosterone, estrogen. And the axis we're talking today about, the growth hormone releasing hormone, growth hormone IGF axis, growth hormone releasing hormone for the hypothalamus, growth hormone pituitary, IGF-1 for the liver, the posterior pituitary, ABP, and oxytocin axis. What gives you hyperthyroidism? My colleague, I think, was here on Friday or Saturday, Kevin Nealon, and I wrote this paper in 2008, that it could be microadenomas can do this. I think this was a major advance. People thought microadenomas were benign, but we found that half of them or so had growth hormone deficiency. So anywhere along the hypothalamic stalk pituitary axis can lead to hypopituitarism, and growth hormone is the first hormone that's affected. Some of the pituitary causes of hypopituitarism include pituitary tumors, macroadenomas and microadenomas, pituitary surgery, pituitary radiation, Sheehan syndrome, which is like a little mini stroke to the pituitary after pregnancy, pituitary apoplexy, hypophysitis, pituitary inflammation, emptyselia, malnutrition and critical illness, and head trauma. The stalk and hypothalamic causes include craniopharyngiomas, CNS malignancy, surgery and radiation, head trauma, accidents, infiltrating disease like histiocytosis X, hemochromatosis and sarcoid, infections, and drugs. Drugs are very common. Steroids, dopamine analogs, somatostatin analogs, opiates also are very important. The order of the hormone deficiency. So growth hormone is the first hormone affected. Gonadotropins are next, TSH, ACTH, prolactin, posterior pituitary. So somebody has a pituitary problem, you got to look out for growth hormone deficiency. So Kevin and I wrote this paper in 2008. We took 38 patients with non-secreting pituitary microadenomas. The mean size was 4.2 millimeters, so fairly small but not tiny. They had normal IGF-1s, which found that 90% and 50% were found to be growth hormone deficient. They had a higher body mass index, meaning they're more overweight. Then also we did a growth hormone releasing hormone arginine test, and they were the patients that were growth hormone deficient, weighed more than those that passed the test. 50%, 19 patients had at least one other pituitary hormone defect, thyroid or testosterone, for example. And we concluded that a substantial number of patients with non-secreting pituitary microadenomas were growth hormone deficient despite normal IGF-1 levels. They had at least one other hormone defect, suggesting that they may not be, these microadenomas may not be clinically harmless. Okay, sure. Okay. Patients with low IGF-1 and microadenomas have a good chance of being growth hormone deficient. Many endocrinologists test for hypopituitarism only if a patient has had prior surgery or radiation to their pituitary. My approach, which to me makes sense, is measure the pituitary hormones and they come in with symptoms related to hypopituitarism or growth hormone. If it points to hypopituitarism, you look at your hormones, you have a low IGF-1, then get a pituitary MRI. So I find a lot of hypopituitarism that I look for. If the MRI shows a small pituitary tumor, IGF-1 is low, the patient has symptoms of growth hormone deficiency, then you would do a growth hormone stimulation test. So it's thought there are more than 50,000 patients in the United States with growth hormone deficiency, including, I guess, this lady that's on the MAGIC website. You know this person? She's on the MAGIC website, so I figured she's probably growth hormone deficient. Growth hormone is the most abundant pituitary hormone. Hypothalamic factors regulate growth hormone secretion by the cells in the pituitary called somatotrope cells that make growth hormone. So it's stimulated by growth hormone releasing hormone and inhibited by somatostatin. Growth hormone receptors are all different types of cell types. And then it goes to the liver to make IGF-1, and growth hormone makes IGF-1 in target tissue. So wherever the growth hormone is supposed to work, IGF-1 growth hormone binds there, IGF-1 goes up, in addition to from the liver. And so you have circulating IGF-1 and sort of local IGF-1, both of them mediate the effects of growth hormone. So you have here growth hormone receptor in target tissues, growth hormone receptor in liver, both of them lead to high IGF-1. So what are some of the symptoms of growth hormone deficiency? In general, patients with hypopituitarism have increased mortality. This is thought to be due to growth hormone deficiency. Not terribly 100% proven, but it seems like as you replace the growth hormone, this increased mortality the patients are getting seems to have decreased. So growth hormone deficiency in adults leads to decreased bone formation, increased fat mass, including central obesity, decreased muscle mass, lipid abnormalities, increased thickness of blood vessels, increased inflammatory markers, impaired quality of life, increased number of sick days, and impaired exercise tolerance. Interesting enough, most of these symptoms are corrected or improved with treatment. So you put a person that has these symptoms, a lot of symptoms here, a lot of times they get better. So patients that are hypopit in this room here, most of them probably should be on growth hormone. And if left undiagnosed, adult growth hormone deficiency leads to increased risk of premature mortality. Significant morbidity means you're sicker. You have multiple signs and symptoms, including increasing fat and body mass, decreased muscle mass, weakness, fatigue, osteoporosis, increased rate of fractures, dyslipidemia, meaning high cholesterol, heart disease, impaired psychological well-being, such as isolation, anxiety, or depression. Bad lipid panel, high bad cholesterol. So this shows a little bit about some of these. It both increases the risk factors. Because you increase the cardiovascular risk factors, you get more cardiovascular disease. So people with growth hormone deficiency have central obesity, high cholesterol, impaired glucose profile, increased oxidative stress. Their cells don't work properly. They have increased inflammation. Their cytokines involved in inflammation are high. And they have endothelial dysfunction, meaning their clotting is affected, so they're more likely to get heart disease from clots in their heart vessels. All these lead to increased strokes, increased heart disease, and people dying from heart disease, which we don't want people to do. So how do you diagnose growth hormone deficiency? You could think maybe you just measure growth hormone. That's not helpful. Growth hormone is made in a pulse. You can be at the top of the pulse or the bottom of the pulse. Just measuring a random growth hormone is really useless and sort of tease out the people that know what they're doing, but the people that measure the random growth hormone or not. So you start with an IGF-1. If the IGF-1 is the top 50% of the normal range for the age, approximately 150, I would say growth hormone deficiency is less likely. If you have empty-sella, history of head trauma, low blood pressure after delivery, that's called Sheehan syndrome. You had like a mini stroke to your pituitary after you deliver. You had a history of pituitary surgery, radiation, a pituitary tumor, either a microadenoma or macroadenoma. Growth hormone deficiency is more likely. And then if the IGF-1 is less than 75, I would say, and again, the ranges are different for different assays, growth hormone deficiency is likely. So you have people that are sort of in the low normal range or the high unnormal range, sort of around that bottom cutoff, sort of around about 100. Those are the people you should do a stimulation test. The classic stimulation test, the classic one is called the insulin tolerance test. About 10 years ago, mostly, I think Kevin Ewan was a big factor in this, people shifted to this glucose stimulation test. The standard has changed, and I think Dr. Ewan's involved in the change. I'd say most people are now using 3 as a cutoff. The NSSI recommends 3 for the glucose stimulation test. Some people use 5, or I use 5. And then this new one called Macrilen. So I'm going to explain what Macrilen is. And this reiterates the point. The IGF-1 is only a screening test. You have several people over here that you can see. The IGF-1 can be quite low in people that are not growth hormone deficient, and the IGF-1 does decline with age. So these are, this is the normal range. Up here you have people that are growth hormone deficient are below this range for age, but you have a lot of people within this normal range that are still growth hormone deficient. So the IGF-1 is a screening test. Its levels overlap between adults with growth hormone and normal subjects, decreases with age, and tends to be lower in people that are obese. So you still want to look at it in the context of the patient's situation. So those people, again, sort of in that low normal range for their age especially, you want to do a growth hormone stimulation test. The classic test is called the insulin tolerance test. It's an IV test. It has 6 blood draws, takes 2 hours, and needs intensive medical supervision. What you're doing is you're making somebody hypoglycemic. And nobody wants to be hypoglycemic. I don't want to be hypoglycemic. I don't want my patients to be hypoglycemic. So you got to have a doctor around to sort of rescue them when they're hypoglycemic. And again, this is what you're supposed to do. You're supposed to make them hypoglycemic. People with heart disease, older people, people with epilepsy should not have this test done. It's sort of hard to do in people with diabetes and insulin resistance because you don't know exactly how much insulin to give them, how much is going to make them hypoglycemic. You can get this low blood sugar, can give you seizures, loss of consciousness. You can get delayed hypoglycemia. You can think you're done with the test, send the patient home, and then their blood sugar drops. So I would say, I never do this test, and I would say it's somewhat going down in favor. I also don't think it's that reliable, by the way. The one that replaced it is the glucagon stimulation test. The glucagon is given IM. There's 9 blood draws. It takes 4 hours. It doesn't really need much supervision. It doesn't work well in malnourished patients. They have people that haven't eaten for 48 hours. Most of my patients eat. It's too much. Patients with a high blood sugar greater than 180 may not work well in it. A very high percentage of people get nauseousness on it. So we have Zofran in our clinic where we give them the test. We give them Zofran. That's the main side effect: vomiting, headache, low blood sugar, occasionally, not too often, sweating, and abdominal cramps. The new test called Macrilen. It's oral. Doesn't require a shot. You drink it. 4 blood draws. A lot better. An hour and a half. Better. It doesn't really need any supervision. Just drink the stuff. No contraindications. The main side effect is called dysgeusia. It means you have a bad taste in your mouth. This happens in about 15% of the patients. I haven't seen it yet in mine. I think we've done this in about 6 or so patients so far. Dizziness, fatigue, headache, nauseous, and hunger are all possible side effects. This was published in Journal of Clinical Endocrinology and Metabolism, August 2018. Garcia is the first author. So what Macrilen is, it's a ghrelin agonist. Ghrelin is a peptide hormone made by cells in the GI tract. Macrilen stimulates endogenous ghrelin. It binds to the growth hormone secretagogue receptor. You can see that on the pituitary there. It comes from the stomach. This stimulates the secretion of growth hormone from the pituitary and hypothalamus into the circulation. And in vivo, Macrilen has similar growth hormone releasing activity as native ghrelin. So Macrilen was compared in this study published by Garcia in a head-to-head study against the insulin tolerance test, phase 3 study. They had multi-center open label, wasn't blinded, which is okay, randomized, single dose, and was crossed over. So there was 157 subjects. Either they got the ITT first and the Macrilen, or the Macrilen first and the ITT. And then they had a reproducibility extension that was only in Europe, 34 patients, to make sure that the second time the Macrilen done was tested and gave similar results to the first test. 140 completed both tests. They had 4 distinct groups, which sort of mattered less when they actually analyzed the study, but it was a little bit interesting. They had a high likelihood group that had structural or hypothalamic pituitary lesions, low IGF-1, 3 or more deficiency, or childhood onset growth hormone deficiency with structural lesions. They had an intermediate likelihood. These are adults that didn't quite have this, but still had a good chance of having it. Low likelihood, they only had 1 history. They might have a distant traumatic brain injury, 1 pituitary hormone, or normal pituitary functions. These are people less likely. And then they took another group of healthy adults. And the endpoints of the study were if there's a positive agreement between the Macrilen test and the ITT test. So they used in the final thing, and I'll explain this in a second, a cutoff of Macrilen of 2.8, an ITT cutoff of 5.1. A positive result shows that the patient has growth hormone deficiency, and they looked at the subjects having growth hormone deficiency with both the ITT and the Macrilen test. Either they had an agreement in both tests for positive, or a negative test shows that they didn't have growth hormone deficiency. So they looked for agreement with both of those as well. And most importantly, 99% of the Macrilen tests were evaluable at the first attempt. These were people that were able to do the test because, again, you don't have to worry about getting an IV. You don't have to worry about people becoming nauseous in the test. Patients all were able, pretty much except for one patient, was all able to do it, the test. And the ITT was only able to be doing it in 83% of the patients. They couldn't do it in a percentage of portion. 17% it couldn't be done. At least it couldn't be done the second time. Some of them. So this talks about sensitivity and specificity. Sensitivity is the result is positive that the person has growth hormone deficiency compared to the ITT, the gold standard. 87% had the growth hormone deficiency on the Macrilen test that was confirmed on the insulin tolerance test. And then specificity means the test is negative and the patient does not have growth hormone deficiency. So 96% is positive. You want a test with high sensitivity and specificity, and this test gave very good sensitivity and specificity. It was also reproducible. So the patients that had matching results, they did it the first time and they passed it or failed it. They did it the second time and the same thing happened. They passed it or failed it. 91% had the same result the second time as the first time. Only 3%, only 9%, 3 patients, it wasn't reproducible. And they didn't look at the glucagon test, the insulin tolerance test or glucagon test. My guess is those would be less reproducible than this one. Here's the side effects. They're all less than 5%. The most common one, the bad taste in your mouth, 4.5%, dizziness, headache, fatigue, nauseousness, hunger, etc. So low rates of side effects from this test. Before taking the Macrilen, the patient should have their other hormones replaced, at least somewhat grossly. So somebody that's severe hypothyroidism shouldn't get this test. They should be replaced with thyroid if they need it, cortisol if they need it, etc. I don't think this is that common in my patients. They're not replaced. They do need a fast for at least 8 hours before the test. This hasn't been proven that it was done, but that's what they did in this study. So they recommend all patients get an 8-hour fast. There are certain drugs that prolong the QT interval. That's the time in the EKG between the part of the EKG when the Q waves come up, between the Q waves and the T waves. Drugs like antipsychotics, chlorpromazine, Haldol, chlorazine, ziperzin, some antibiotics, some anti-arrhythmia drugs, they all prolong this test. It doesn't necessarily mean you can't do the test if they're on this. You might try stopping these drugs if you can. Most of these drugs people do. I don't think this is that major an issue, but I don't have any patients that are on these type of drugs, but you certainly should be cautious if they are. And then there's these drugs, and I think I'll show that on the next slide, the CYP3A inhibitors. These, sometimes it's recommended to stop them. Some of these you can't really stop. These are more common drugs. And you certainly want to not give the person growth hormone if you're testing them for this test. You need to stop it. I would say it's like about 3 weeks. They say 1 week. I would give it about 3 weeks before. There's a supplement I use called Cerevital. There's another one that I used to use called D-transtropin. If you're on any of these things, you should stop it before the test. Probably about 3 weeks before is good. So the patient drinks the solution. They have to drink the entire volume. They have to drink it within 30 seconds. You got blood samples at 30 minutes, 45 minutes, 60 minutes, and 90 minutes. And you spin the samples and send them to a lab where growth hormones measured. Pretty easy. So these are the CYP3A4 inducers inhibitors. So a inducer, on the comment over there, may reduce Macrilen levels and lead to a false positive test. Your growth hormone may be, you may look like your growth hormone is lower because you're not getting that Macrilen in properly. And these drugs are pretty common here. You know, steroids, probably high-dose steroids. I don't think replacing effects of St. John's wort, anticonvulsants, carbamazole, pioglitazone used for diabetes. The inhibitors on this column over here may increase Macrilen levels and lead to a high false negative test. The patient would fail the test even if they have growth hormone deficiency. These again are common medicines: H2 receptor antagonists, protease inhibitors, fungal things, ketoconazole. Probably you don't have a lot of patients on ketoconazole. I'll talk about that in the next slide. Amiodarone, SSRIs, those are very common to use. So I don't think patients need to stop glucocorticoids before testing. I think if you're on replacement dose is okay. You may want to stop ketoconazole. If you can't stop some of these drugs, probably a week before you do the test, just to make sure. So the cutoff is interesting here. So in the paper, they had a cutoff of 5.4. This was the value right over here. This was the value that gave the best sensitivity and specificity of the Macrilen, that patients didn't have it, who weren't supposed to have it, people that had it were supposed to have it. So 5.4 was the cutoff. However, the FDA felt they don't want people diagnosed with growth hormone deficiency, don't have it, they want to be extra cautious on that, so they used the 2.8 cutoff. So the FDA has a cutoff of the test of 2.8, although the paper in JCNM found that growth hormone of 5.1 gave the highest separation between normal and growth hormone deficient patients. So again, I try to look at the patient as a whole. If they have a lot of things going for growth hormone, they have pituitary surgery, they're hypopit, they have a real low IGF-1, I would probably start it for somebody who's between 2.8 and 5.1. I may have to fight with insurances, but I would probably start. If somebody has less history, I might go with 2.8. So this, again, is only in my clinic. Here, other people, places do this test. I think, again, at here in Bartow, they do the test at probably for billion insurance, I don't know. The glucose test, I charge $695. It does not need a pre-authorization, requires an intramuscular injection. Most patients get nauseous, disadvantage, has 7 blood draws. The Macrilen Stimulation Test costs $350, requires a pre-authorization that seems to take a long time. The company thought it would be very easy to get this pre-authorization. Part of the problem is the insurance companies aren't familiar with this test. They think it should go under medical or pharmaceutical benefits. So we've had some trouble getting this covered. And if you don't cover it, the company charges you $5,000. The company may give you a discount or they may have a copay. But in general, the people that you need time to do this pre-authorization, the people the pre-authorization fails, I'm sort of going to push them over here to do the glucose test.
We could just pay you $350.
Yeah.
And no sweat.
No. You have to get the drug. You can take it $350. I'll happy to have the money, but you won't get the Macrilen.
But I can't do the test, even if I pay you the $350.
Right, because the company won't authorize it. The company's charging you $5,000.
Okay.
Good question. It's an oral solution. It requires 4 blood draws. I offer this on Tuesday night when the patient comes from out of town. Let us know in advance. We'll try to do the pre-authorization for you, and we'll try to put the test in on the same night you have your appointment. But you do need a fast for 8 hours. That's what the company says. So you have to sort of come see me. You can be jet lag, tired, and hungry all at the same time. But hopefully it'll be okay. So one of my patients asked me, what about doing this test late at night? So they're coming from a different time zone. They get to LA. It takes them a while to start the test. And we know that growth hormone goes up at night. The question is if it's just going to go up at night and you're going to pass the test, your growth hormone is going to be high because it's late at night. So the answer is no. It can be done at night. The answer is yes. I guess, can you do the growth hormone test at night? And this is because the growth hormone goes up when you go to sleep, not at night. So you can be jet lagged, if it's 3 in the morning, as long as you're awake, your growth hormone stays pretty low. And this was done by a paper in 1968. I always like looking at old papers. This guy, Dougherty, I think maybe lives in Los Angeles area. He's born in the 90s, might have passed away. He sort of was the pioneer of IGF-1 and growth hormone. So he did a study here that looked at people, different people, but they have an example here of a normal person. The person started going to sleep at 10 o'clock. The growth hormone started going up and was pretty up by midnight after the guy was asleep for 2 hours, and then it went down, as you can see. And then what they did is they had this person delay sleep. He didn't go to sleep till 2 in the morning, and sure enough, the growth hormone didn't rise till after he went to sleep. So it really doesn't have to do with the time of the day. It has to do with the going to sleep. So I feel pretty safe that you can give this test pretty late at night and not have a problem. So if you want to do this test, you want to schedule an appointment, go to my website, go to hormonehealth.com. We'll post the talk in a couple of days. I think we have time for a couple minutes, and we have a little break for bathroom to move into that back there. So we have a couple questions here.
One couple of lifelong growth hormone, do you consider IGF-1 to be an accurate test to see what their levels should be at?
Yeah, I do. It varies somewhat with each patient. Some of them, the main side effects of too much growth hormone, high IGF-1, is joint pain and swelling. So somebody may have that joint pain and swelling side effect that an IGF-1 near the top of the range, but in the range. And then at the back, somebody who might be doing well. I try not to push it above the range, partially because if it's above the range, I think it's because of cancer.
What's around hyperthyroidism? Why can
can have a normal IGF-1, but then will test.
So there's sort of two different tests, actually. The IGF-1 has a wide range of sort of screening tests. So the IGF-1 could go between like 90 and 350. So you could be 88 and still be not growth hormone deficient, or you could be 110 and be growth hormone deficient. The IGF-1 is screened. The gold standard set by endocrinologists basically are the stimulation tests. So you really have
variability
there's a
with the IGF-1.
little bit of variability with IGF-1, and certainly a variability with the growth hormone. Hopefully these stimulation tests, and that's why I like that. It's pretty reproducible. It seems like it works. Yes, sir.
If you're already on growth hormone, is there a preferred time of day to take your dose?
Good question. So people with growth hormone, if you can sort of see that picture, in general, is more at night. Certainly in men and kids. In women, it's not so clear, it's a little more evenly balanced. But because I think we think that growth hormone is secreted at night, helps you with your sleep, I usually recommend it. I thought someone was going to ask you the question. I don't know. I'll answer the question. So, do you need to do that Macrilen test every time? You're going to do that test every time? The answer is no. Once you're diagnosed with growth hormone deficiency, that's all, you only need it once to get it most of the time. Occasionally, insurances will, say this test is so old, we want another one. But I have to see it. So basically, the insurance diagnose you with the stimulation test, follow you with the IGF.
That even after 4 or 5 years of being off of it?
Being off of it or on it? If you failed the test before, I think you'll probably get it covered.
And if you stem at 0 on both IPC and the Glucagon, does that indicate anything else to be on the box for?
Well, I would say you're probably more likely to have more Hypopituitaris. Not necessarily true, but I would say yes. Probably should look for the hormones as well. Yeah, any questions? Maybe I'm happy to come. Okay, so we want to move over. Oh, we have one more time. One question. Over here.
What other factors could influence IGF-1? For example, I seem to be high, my dose was reduced very slightly, and I fell off the bottom bar. So, like, she mentioned high protein diet.
I don't think hyperthyroidism matters that much. Testosterone weighs with it. I did a study on giving women testosterone, it would cause IGF-1 up. Other hormones sort of affect it sort of subtle ways. So I just think you have to keep testing it all the time and monitoring it, and it starts dropping. Obesity, gaining weight also could do it. Losing weight could probably help with it.
Bring it down or
Oh,
up.
right. Okay, so it's time for a bathroom break, and people, we want to move.
We're staying.
We're staying here. We're just opening it up, okay? There's, I guess, drinks over here.
Yeah, get a glass of water. Yeah.
Let me just turn this up.
I'm back